benefits of home hemodialysis. And, whoops, Dr. Brent Miller is the professor of clinical medicine at Indiana University School of Medicine. He is the Michael A. Krause Home Dialysis Professor of Nephrology and is internationally recognized as an expert in home hemodialysis. Dr. Miller is passionate about advancing the care of his patients through patient care, education, and research. Without further ado, Dr. Miller, the floor is yours. Would you like to share your presentation, please?
I will. Thank you, everyone.
This event is being recorded, okay? And please put your questions in the chat box and I will monitor the chat.
See here.
Thank you, Joanna. Appreciate it. Look
Yes,
forward to the presentation with Dr. Miller. Thank you.
thank you, Jay. Um, Dr. Miller, Jay is our RVP for the company.
Oh, nice to meet you. Can you see my slides now?
Yep.
We can. Would you like to put it in slideshow?
Yes. Right, so
Perfect. Thank you.
welcome, everybody. And the title of my talk today is Management of Home Hemodialysis Complications, which is a large topic. And obviously, when we do hemodialysis, we will often have the same complications at home that we have in center. And so I actually changed the kind of the topic to really prevention of home hemodialysis complications, because really what we're trying to do in home hemodialysis is we're trying to mitigate those complications that we have in center. Hemodialysis is, no matter how safe and how well we do it, is always going to have some complications. And we want to really eliminate the risk of having those at home as much as possible. So that's the target of my topic today. And one of the things that I'm always intrigued, I always go back to this slide to point this out. And this is a vascular access slide, but I think we could apply it to almost everything we do in home hemodialysis and peritoneal dialysis, and perhaps in healthcare in general, which is this group of people looked at 19 home hemodialysis training centers, and they looked at how well the patients and the nurses did on following generally accepted practices for managing the vascular access. And then they graphed how the nurse did and how the nurse's patient did. So you can see that, and it's a linear, no surprise here. I mean, it's obvious, but I think it really hits you hard when you look at this, that if the clinicians, which were predominantly nurses, didn't follow the practice, the patient didn't follow the practice. And so, there's two messages there. Is one, when we are training the patients and when we're seeing them in clinic and we have opportunities for retraining or education, we should utilize those. And then also we should practice and demonstrate those. But then the patients also need to follow what we're doing. And by doing that, we likely eliminate a lot of the problems. But this now is 7 years old, but it's just always striking to me. And I have 4 children, and I guess I shouldn't be surprised that if you don't model the correct behavior and you don't teach the correct behavior and people don't get into a routine of the correct behavior, then that is what will be practiced. And unfortunately, and this is a vascular access slide, you'll end up with complications because of that. But don't underestimate your ability to control and prevent complications by how you train, educate, retrain, and re-educate the patients. So with that as an overview, when you look at the complications of hemodialysis and hemodialysis, we can divide them into 5 areas generally. I could talk about an hour for each of these subjects. We don't have that time nor interest, and many of them, it's hard to mitigate. They're known complications. Many of them, there's no difference in the complications from in-center to home, so I won't dwell on those. But I will break them down into areas. So 1 is water and dialysate. 2 is the machine and the extracorporeal circuit. 3 is vascular access. 4 are some clinical issues surrounding home hemodialysis. And then 5, and I don't have a lot of suggestion on this, and I left it at the end, and if we have time, we can discuss it, is one of our largest complications of home hemodialysis that I don't know that we've figured out how to address perfectly, is patient and caregiver burnout. So I'll start with water and dialysate issues. And it's amazing if you look back at this over the last 60 years, because we've been doing home hemodialysis now for almost 60 years. I believe the first home hemodialysis patient was 1964 in Seattle. So we're coming up on the 60th anniversary of home hemodialysis. Was the enormity of the problems in the water production and purification, and the problems with dialysate production and contamination. And it's improved so dramatically, and I think we forget this, that we rarely even talk about it. But so I'm not going to mention all of the water complications. And the fact that now you have basically 4 different types of home hemodialysis systems for the water, and potentially, there's a 5th one approved by the FDA. There's a 6th one working its way through the FDA. So you have all these options. And the amazing thing is the ease and success rate of making water is amazing compared to what we had to deal with 30 years ago, 40 years ago, 50 years ago, 60 years ago. But as of now, you have reverse osmosis and a deionized water that can be made at home. With those systems, you have a batch system, which uses DI to do that. You have bag dialysate, which is produced elsewhere, and you can hang the bags like we do for peritoneal dialysis at the home. Then also in terms of the complications from the water, and these are something that I'm not going to discuss further because you all know them, the AMI standards and your water cultures and doing your home visits and making sure things are okay. But the infectious and contamination issues from water has dramatically improved. We rarely talk about aluminum transfer from dialysate to the patient anymore. We don't really even hear about things like nitrites and other heavy metals that get into patients' bloodstreams through a dialysis procedure anymore. So it's improved dramatically. And because it's improved dramatically and we basically don't see it, just to skip over to other things, I'm not going to talk about it further. But obviously, if you see something that would suggest that there's a problem, you see all of a sudden hemolysis or other problems, you want to investigate it, because that used to be the history of hemodialysis, both at home and in center. Then the dialysate, there were previous issues with dialysate where it would be contaminated with, let's say, aluminum. The buffer might be contaminated with aluminum that would leak into the patient's system. And those issues do not occur anymore. So now, this is not a clinical issue, but even though we've largely mitigated these issues, that does not mean we don't have issues with water. And to be honest with you, this is an area that I've had more problems with, which is not a clinical issue to the patient, but this is a picture from a patient's house that they sent me, where the water purification system, and this happens to be a pure flow here, had a leak in it. And so some water got onto the patient's hardwood floor and then damaged the floor and resulted in a several $1,000 repair to a hardwood floor. So So the message there is you can still get a complication from water. And if you're going to put your pure flow in a very nice hardwood floor area of your house, yes, it's probably not going to leak, but there's plumbing, there's water, there's connections. We should probably try to mitigate that risk. Other machine issues. And these machine issues, just a minute here. I actually came home to do this talk and my dog is barking. If everyone doesn't mind, I'm gonna see what I'll be right back. Give me 30 seconds.
No.
So I think, just to share an experience, I think some of you might even have better experience than I do, is some people buy one of those like either washing machine pan or refrigerator pan and put the pure flow machine inside. So if it is just a small leak, at least it's not going to ruin the floor. But if it is a big one, then yeah, of course, we'll have some problem. And definitely, yes, I just experienced repairing hardwood floor is very expensive.
Yeah, and water alarms too. In other
Yes,
words, placed on the floor.
that's a good idea. I don't think we have that, but definitely need to consider that. Thank you, Jay.
I know when we rolled out Tableau machines, Jen Anderson, she would help us purchase those square mini tarps, which goes under the Tableau machines. And I think you can also use them for next stage too.
Mm-hmm.
All right, sorry about that, everyone. I'm back.
Okay.
So these other issues can and will occur on home hemodialysis, but they're at similar rates to what you see in the center. So you can still have dialyzer reactions, type 1, type 2. You can have a leak in the dialyzer, which happens about a few times in a million treatments. And that's been consistent over the last 20 years. Cartridge leaks. So the plastic cartridge and the tubing can sometimes have leaks. Again, the incidence of that's about 1 in a million. Hemolysis, which in today's world is generally due to problems with vascular access, can occur at a rare rate. And then with high flux membranes, you can have back filtration, which generally isn't an issue unless you have a problem with the dialysate. So these are rare complications that can still occur. Now, I have seen all of the first 4 in home hemodialysis patients, just because I've been doing it for over 20 years. But the number of times I've done it, seen it, is just a few. Now, there are other problems that aren't really, that you'll notice that perhaps, they're complications. They don't have disastrous consequences to the patient. But here's one. So this is a next stage cartridge here. And this is a header. And you can see that there's some white precipitate at the top. And ultimately what that is that's fibrin deposition in the header, likely due to some turbulence there. And you'll see that start to occur. And then if you let it go on and on and on, you'll see the next window over here, there's clotting of the dialyzer. So in general, you will occasionally see this in a dialyzer. My answer has been to make sure that the patient is adequately anticoagulated and to watch it to see if it occurs again. But this is a pretty uncommon complication also. Then this doesn't happen with the machines that we typically use now, but this is a problem with an RO. And again, this just shows if the patients don't follow the directions exactly, you can get into problems. So what happened is this was a home hemodialysis patient in Canada that was using a standard machine and a standard RO system. The picture of the RO system here is on the right. And what the patient did is they misconnected the RO system to the machine so that the water coming out of the RO system that went to the machine and thus the patient was not the product water. It was not the purified RO water. It was the effluent water, the wastewater. Therefore, the wastewater had a massively high calcium concentration, and the patient became ill in about 30 to 45 minutes. And by the time they got to the hospital, their calcium level was almost 20. So, and it was a simple error that connected to the wrong outlet on the RO machine. So again, these are this wouldn't necessarily happen with the technology we typically use in the United States right now. But these are things to keep in mind, is that patients do not do the home hemodialysis procedure as they are taught. It can lead to problems. This is an example from, I believe, New Zealand. It's either New Zealand or Australia. I forget which one. And it was at the standard dialysis machine. And again, what happened is the patient did his dialysis by himself. And unfortunately, he connected the saline the wrong way, as you can see on the left, at the conclusion of the treatment. And so he basically exsanguinated because the blood, instead of being returned, it went into the saline bag. So again, user error, somebody doing something that was not according to directions that led to a complication. So those are machine issues. Well, now let's move on to probably something that's more commonly seen and actually one of our larger problems on complications of home hemodialysis, which is the vascular access. And I'll basically talk about, actually there's a fourth I'll talk about, but we can have sepsis, we can have air embolism, we can have venous disconnect. And an infection is a huge problem in dialysis, as you all know. It's a problem in PD with our peritonitis. It's a problem in hemodialysis with our bacteremia of fistulas, grafts, and catheters. Here is the 2016 QIP bacteremia rate, which was based on 2014 data. I haven't updated this. I probably should update this slide, but I can tell you it doesn't look a lot different, so I haven't updated it. This is something that you want to very carefully follow in your home hemo program, because it's going to tell you if you have a problem that needs to be addressed with more training and more education, and in terms of the patients not following standard technique. And so this is the way you can measure it in two ways. You can measure your bloodstream infection rates in terms of 100 patient months or 1,000 patient days. In our program now, we measure it per 1,000 patient days. So we measure it on the right side of that graph. And it's fairly consistent what it is for fistulas, grafts, and catheters. And you can see, as no surprise, that the catheter infection rate is 8 times what a fistula infection rate is in terms of bacteremia. But if you start to see that your home hemodialysis as a group, your infection rate with fistulas is 0.2, or you start to see the graft infection rate is 0.3, or you start to see your catheter infection rate is more than what you would get in center at 0.72, it tells you that there is likely a problem with how the patients are managing their vascular access. And just to show you that there's a marker that we have a problem in the United States on home hemo, this is Eric Weinhandel's paper from 2015 that did show, and basically this data looked incredibly positive for home hemodialysis patients in every respect except one, and that's infection. So home hemodialysis infections were admitted to the hospital sooner for infection than matched in-center hemodialysis patients. So there's a signal. I mean, this is just an observation, but there's a signal that although we are providing a great service to our patients in terms of almost every outcome, blood pressure control, mortality, overall hospital admissions, transplant rate, it seems that home hemodialysis patients do very, very well in many, many, many things. This is one where we have a marker that there might be an issue. And so we really need to concentrate on trying to prevent infections, and particularly infections due to the vascular access. This is an earlier paper by Eric, which looked at this basically how 2,000 home hemo patients did compared to matched 9,000 controls over 4 years in the USRDS database. And it's interesting because this is the paper, now it's 10 years old, that got a lot of attention because it suggested that home hemodialysis in the United States had a 13% improvement in mortality. However, if you look specifically down there, the one area where there was not an improvement was the deaths due to infection. And of course, a large percentage of those deaths, the most common cause of those deaths, are bacteremia related to vascular access. So again, you have a marker that suggests that we're not doing as well with the complications of infection and vascular access as perhaps we should. And this is a review of home hemodialysis patients from Australia, and it showed that basically, and you remember we talked about the infection rate with fistulas per 1,000 days, and that in the United States, all comers, the average in center and home, everyone thrown in there together, lumped in there together, is 0.09. And you can see that the total infections with buttonhole or systemic infections were greater than with the rope ladder. That's the the third and fourth triangle that's there. So you can see the systemic infections with buttonhole were about 0.2. The rope ladder, or the way we typically use it with sharps, were about 0.1, which is about the average. And so this suggests that we have a little bit more infections in home, at least in Australia, and that when we use buttonholes, those infection rates are about double what the average hemodialysis patient is. So that suggests we may need to pay more attention, in particular, to how we manage our buttonholes with vascular access. Next is access rupture. You know, we don't often see this because it doesn't happen right in front of us. When people's access ruptures, it usually ruptures outside the dialysis center, and actually accounts for almost 1% of hemodialysis patient deaths in the United States. It's just that we don't see it happen in front of us. So what we want to do is, one, we want to recognize that there might be a problem. And this is one of my patients, and you can see that his access was starting to get thin. And so it's like, listen, it's getting larger, it's starting to thin, we need to repair this. And you can see we addressed it. And in 4 months, we have this totally taken care of. But the reason that you get that in general, is because we may not be cannulating exactly right. And this is with the sharp needles with rotating site. But this is the type of cannulation that was done. This was done across many centers in many different countries, but it looked at 171 dialysis centers, 10,000 cannulations in separate patients. And over half the cannulations were what was called area cannulation, where the cannulator is putting the sharp needle repeatedly in the same area. And when you do that, that's what weakens the wall and leads to an aneurysmal dilatation, like on the left side of the picture here. So when we want to be very precise when we choose what time of cannulation, whether it's buttonhole or rope ladder. If we choose buttonhole, that's fine, but we need to be very meticulous about our aseptic technique. If we choose rope ladder as our choice, obviously we still need to be careful about aseptic technique, but the data suggests we're doing about the same as in center. But what we have to be careful about is that we choose the sites and how we cannulate with rope ladder very well, so we do not put ourselves at risk for choosing an aneurysm. And this is human nature, and especially for patients or their caregivers. If I have success sticking the needle in one place, I'm probably going to go back and stick there again the next time. So that's an area where we really need to make sure the patients understand that, no, you need to rotate the access cannulation site to not have this complication. Next complication of vascular access in hemo and home hemo. And I've seen 2 instances of this. Fortunately, neither was life-threatening. So when air gets into our system, into the vein, it goes to the lung, and hopefully it will diffuse out. But once you start, if you get more than somewhere between about 3 and 10 milliliters of air injected into your venous system, you will start to have symptoms. These will typically start as chest pain, dyspnea, tachycardia, and so forth. And if you get 50 milliliters of air, that's uniformly fatal. Now, somewhere between 10 and 50, you can have various other symptoms. And here's one of the bad complications of an air embolism. And this is where the air goes to your head and goes to your brain and causes a stroke. And in today's world, with any extracorporeal circuit, hemodialysis, plasmapheresis, platelet donation, the risk of having an air embolism is about 1 in 30,000, but it's not from the machine anymore. 50 or 60 years ago during hemodialysis, air embolism could occur while you're sitting there on the machine and you didn't have a drip chamber, you didn't have an air detector, and you could have air get into the system just running on the machine. That doesn't happen anymore. But what happens is we introduce air when we manipulate the vascular access. And so again, this is a really critical point, that the patients have to manage their vascular access exactly as we teach them. In one of the studies I was involved in with the National Institute of Health called the Frequent Hemodialysis Network Trial, this is 15 years ago, we had people across the country doing nocturnal home hemodialysis at home. And unfortunately, at the University of Iowa, they had a patient death when, after the treatment one day or one morning, a woman, her husband had gone, she was the caregiver, he had gone into the other room, and she decided to unhook herself from the dialysis machine. Unfortunately, she had a CVC catheter. She stood up to unhook herself and unhooked herself, and standing up, taking a deep breath, air went into the catheter, into the right side of her heart, and then up into her brain, and then she died. So this is a rare complication, but it's almost always due to operator error. And again, we need to encourage people to follow the directions. Other complications, which are more clinical in nature and not vascular access, and the largest one, are issues revolving around ultrafiltration, hypertension, hypotension, and what we call stunning. When you aggressively lower blood pressure quickly and fastly in a patient, even without symptoms immediately, you can intermittently stun vital organs such as the heart or the brain. And if you do that repeatedly over years and years and years, you can have long-term organ damage. So although this isn't proven yet, the stunning is, because we can do PET scans and other studies that show that when we aggressively ultrafiltrate patients significantly, we can show that their heart or their brains get stunned. The thought process is that over a long period of time, by having repeated stunning of your heart or stunning of your brain, that may lead to cardiac dysfunction, or it may lead to cerebral dysfunction and even dementia if this happens repeatedly over years. So one of the things we want to make sure is we're choosing the correct target weight for the patient on both sides. If we don't choose the correct target weight one way, we get hypertension. If we choose it too aggressively, we get hypotension. And then we want to make sure, and it's supposed to be ultrafiltration rate, that we choose the correct ultrafiltration rate. And what that rate should be is currently being debated very vigorously. I think, and everyone has a different opinion of that. Medicare came out a few years ago and said in the QIP that we think the ultrafiltration rate should be less than 13 milliliters per kilogram per hour. Most people think that should be 10 or less. There are a few people that think it should be 8 or less. There are a few people that think it should be 5 or 6 milliliters per kilogram per hour per less. But that that number is very, very important because that is going to reflect your hemodynamic stability and also is going to put you at risk for stunning your vital organs if that number is too high. So that's why we're not real excited, even in our this doesn't happen in a home patient very often, but it does tend to happen in center, is somebody will come in with 4, 5, 6 kilograms and they'll say, oh, they can get it off. They do okay. They might cramp a little, but they do okay. Well, yes, they might do okay that day, but taking fluid off at that rate repeatedly over a long term is going to have complications for the patient. Electrolyte disturbances, I don't really want to discuss too much. They're basically the same as in-center hemodialysis. Obviously, we don't want people hyper and hypokalemic. We want to control their acid base correctly and so forth, but those are relatively straightforward, and I won't bore you with that because it's the same as you do with any hemodialysis patient. Anemia, I think it is important to manage this well at home. EPO is managed very similar to, or now we might have HIFs coming very, very soon, similar to in-center. The iron administration can be done at home or in the clinic. I've done both. It works fine either way. Now, this will be my last area, and I think it is one that I'll point out. I don't know that I have any great solutions for you. It is a work in progress for myself and my team here in Indiana, and it's still a work in progress for my old team in St. Louis, is patient and caregiver burnout. It's still by far the number one reason for technique failure in home hemodialysis, particularly in the first year, up to 40%, which is stunning. I mean, it's an amazing statistic that 4 out of 10 of our home hemodialysis patients in the United States will leave home hemodialysis and go to generally in-center hemodialysis. A few go to PD, a few quit, but they go to in-center hemodialysis largely because they say the treatment is too hard, too much time, too complicated, too hard. Not because they're not doing well, not because they don't know how to do it, but this rubric of burnout. And it's interesting because we have 40 plus years of peritoneal dialysis, and patient burnout or psychosocial reasons are always in the mix. They're one of the 5 reasons that people leave PD to go to hemodialysis, but they're rarely, if ever, the first reason in any programs, and they're usually number 5. So, and this has been true for at least 25 years. Why do people leave PD? Number 1, peritonitis. Number 2, catheter problems. Number 3, ultrafiltration failure. Number 4, inability to get solute clearance. Number 5, psychosocial. Now, your mileage may vary. Programs and places in the country might be a little different. Psychosocial may move up to 3 or maybe even occasionally 2 in some places. But it's almost never, I've yet to see a PD program, maybe there's one out there, call me if there is, that the number 1 reason their patients leave PD is psychosocial. However, on home hemodialysis, you occasionally will have people leave because of vascular access problems. You'll occasionally maybe more than occasionally have people leave because of intercurrent medical problems. They've had a stroke, they've had a heart attack, they had a hip fracture and have to go to rehab, whatever. You will have some people that have problems with infection, but by far, the reason in almost every program people leave home hemodialysis is patient and or caregiver burnout. So how can we prevent that? And one is, I think it's early involvement of the social work team, I think, is critical in communicating with them on a regular basis so that we start to pick up on signs of stress within the patient or the caregiver or in the home and address them. So the way I do this in my clinics is my social workers come to my home hemodialysis clinics. I won't say every month because nothing's 100%, but almost every month. So we are talking about this with the patient, with the caregiver, with the social worker, with the nurses, with the dietitian, with the APPs, with the physician, every month to make sure we're not missing problems. And so then it's like, once we pick up problems early, how are we going to address? One is maybe we need to do some home visits and just go through, well, why did you do fine in training, but now all of a sudden you get home and this is becoming too stressful? So let me come out and let's take a look and let's see how things are set up at home and how you're doing it. Offering respite care is very important. And so we can say, how about let's take a break. Let's press the pause button. Let's come either to the home training area or the home unit or the in-center area, and let's just do dialysis. We'll do dialysis for you for the next 1, 2, 3, 4 weeks. And let's let everything kind of calm down, and then let's take another try at this so that we're not putting people, so we don't push people to fail. And then the other thing is that in my programs, and there's some data on this nationwide, that the patients that are the most likely to fail are the ones that are most reliant on their caregiver. So the more steps of the dialysis procedure, broadly defined, that the caregiver has to do, the more likely that patient will be a failure on home hemodialysis due to technique failure. So we want to encourage the patient to do as much as possible. And it doesn't have to be some of it's not necessarily the dialysis procedure. Can you order your own medicines? Can you organize your own supplies for the treatment? Can you get the supplies out for the treatment and put them on the table before the treatment needs to be done? Can you help clean up? So there are all these things that even if somebody has a lot of the comorbid problems our patients have, they should be able to manage at least some of those procedures. So that is one of the things I think we need to communicate better from the beginning, that you are the patient with the disease. So you need to be able to do as much of this for yourself as possible. And then lastly, from a clinician standpoint, sometimes I adjust the prescription for home hemodialysis based on quality of life and being able to maintain the patient at home. Now, I don't go below the recommendations from KDOQI. I don't do inadequate dialysis. I don't do things that are not in the patient's best interest. I don't do things that are less than what they would get if I transferred them to in-center. But rather than myself holding out as the clinician for the perfect prescription, I might make something a little bit less than perfect or less than ideal because I know that the patient and their caregiver will have a better quality of life based on that. And with that, I'll stop talking, and I'm happy to take any questions or comments.
No, thank you for the presentation. Very informative. And I just put something in the chat, and I wonder if we shouldn't take a proactive approach to respite care with some of these patients that really rely on their caregivers maybe more than others. Something that the caregiver can actually look forward to.
That's a great point.
Yeah.
Yeah, that's just a great point. Some of my friends, my colleagues do that. I have not crossed that bridge yet, but several of my friends do. They say, like, we are gonna do either a 1 week or 2 week respite every year or every 6 months. You're absolutely right. And
yeah, it's a risk getting them in center, assuming that's where they go, but I think it's the lesser of evils, if you will. Yeah.
And so I have not done that. I guess I'm just not quite as authoritarian as maybe I need to be. But I do mention, I do offer it all the time in clinic. And there are occasions when things are struggling where instead of making the nurses be the bad cop, I take on the roles of bad cop. So when things aren't going well, there's a problem. We've talked about it with the social worker, the dietitian, the nurse practitioner, everyone knows that we're heading down a bad pathway. Then sometimes I'll say, you know what, I'm going to take this out of your hands. I think you need to come in center for 1 or 2 weeks. This is not a failure. It doesn't mean you aren't coming back, but let's go and let's get this situation taken care of, and then let's restart at home in a week or two. I have done that.
Yeah. Makes sense.
Yeah, we do have a process to evaluate the need for respite care. So I agree with you. The social worker role is so crucial and critical here. Of course, nurses too, but the whole IDT is play a part. And Dr. Miller, I have a question for you. You talk about, if the patient doesn't want to do anything, that might be almost like a recipe for unfit start for home hemo. We just had had a patient, and when I interview him, because, physician asked the patient, I think home hemo will be best for you. You're not doing so well on PD, something like that. But the patient, the first thing he said, I enjoy being served. My wife takes 100% care of me. So in other words, it's like he already make it very clear. He doesn't want to do anything, even with his daily care, despite the fact that he's young, in his early 60 or late 50, but he likes to be served. What do you think about that kind of patient being evaluated as a candidate for home hemodialysis?
No, I agree with you. That to me, that's a big red flag. And in those cases, what we've done is we've had typically the social worker, but occasionally me and the social worker, or the nurse and the social worker, or me and the nurse and the social worker meet separately with the patient and the caregiver. Because sometimes when you meet separately, the caregiver will, they're not willing to say that in front of their spouse, but alone they might say, I'm really worried about this, I don't think I can handle it, that my spouse thinks I'm going to do 100% of this, I'm working full time, I'm already doing this, I'm doing this, I'm doing this, I just don't know how I'm going to add this to my plate. And we've had that several times. And in that case, what we do is it's a little bit like when somebody is pressuring somebody to donate a kidney transplant. And when you talk alone with the person, they said, I'm just not comfortable donating this kidney at this point. You don't then go back to the patient and say, guess what? Your sister doesn't want to donate, so we're not going to do it. You never do that.
Mm-hmm.
And so I think it's the same way here, which is you have the the team basically say, I don't think you're ready for this. You're capable. We think you should do this. And the patient may say, well, no, I'm going to be served by my wife. And as the caregiver group, we say, well, we don't think, we think you should be doing this. This is a home modality. It's your disease. You need to be doing this. That's, a few patients have gotten angry at me for doing that, but in the long run, it's worked out pretty well. So that's my personal opinion. I don't know if anyone else on the call has any great suggestions, but I agree with you. That's a big red flag that this is not going to work well.
Yeah, I just wanted to comment, I thought it was interesting, how you provided the history. And I think, we don't think about, the early days of dialysis and how dangerous it really was for patients, just water alone. And we've come a long way. I mean, we don't even think about that anymore. So appreciate you giving
No,
the
it's all in the
history.
background. I mean, we still have to, obviously that's why we follow our AAMI standards and we do all the things we do. But it is amazing that we're not every 3 or 4 months shaking our heads with somebody that had some terrible contamination from our dialysis procedure, despite our best efforts. No one's getting the hemolysis from stuff. No one's getting acute aluminum toxicity. No one's getting a lead toxicity. No one's getting nitrite intoxication. No one. It's just, and when you look back, if you look back through the 60s, 70s, and even 80s in dialysis, that was being reported all the time.
Yes. There's a question in the chat box. What about nocturnal every other day? I would say every other night. Yeah.
Yeah, I love that. I have I've had patients on that. I think that's great. I've loved that. And I have people, obviously I have people, we have a few people, we have one center here in Indianapolis, and I believe there are two in St. Louis that do a night shift nocturnal in center. And obviously they'd be doing it 3 times a week. So I'm a proponent for that. It's always been just a niche therapy with a few patients choosing it, whether it's at home or in center on the every other day nocturnal or the 3 times a week nocturnal. But I think it's a better therapy if you can sleep than 3 times a week. So I'm for it.
Yes. Yes, that's great. And actually, we recently have made a procedure change because it has been a challenge for the field for us to find the right syringe pump for heparin infusion during nocturnal hemodialysis for home patients. So Dr. Abra did some research, and then we have initiated the use of enoxaparin, just a loading dose before the treatment, and then it seems to is effective for the nocturnal patient to go through without any maintenance anticoagulant throughout the whole night. And it saves some money, saves some training, and then it potentially it can increase the number of our home nocturnal hemo patient.
I mean, it certainly takes away one complication and having another machine. Uh, and I think again, looking at those types of anticoagulation strategies is something that we can do in today's world, because another advance that we tend to poo-poo and we don't really talk about is the basic, I'm going to call them airless lines, but that's probably not exactly true. But the amount of, so clotting occurs in an extracorporeal circuit when air hits the blood. In today's world, especially with the system that we typically use, the amount of interaction between the air and the blood is much, much, much less. So your risk of clotting goes lower. So the idea that you have to use this massive bolus of heparin and have a continuous heparin infusion in everyone is probably no longer true. And so it really does yield to the idea that we could use enoxaparin or some other simpler anticoagulation strategy and not get clotting in the patient on nocturnal hemodialysis.
Yes. Thank you. Okay.
Given that, what's your opinion on a large bolus pre-treatment of heparin as opposed to an hourly?
Well,
Do you see that often in practice, or
you mean on
years
home
ago we used to
hemo
do
or in
it?
center or acute, or I mean, where are we talking about?
Yeah, home hemo, or even in center for that matter.
Yeah, so you know, I do predominantly. I still see some in center patients, but I do predominantly home. Uh, I mean, to be honest with you, I don't, even though the initial orders will often say 50 units per kilogram. I don't think I'm doing that much in people now. I would say I'm using more like 30 units per kilogram or less on my in-center patients. And then the hourly kind of depends on how they do. On my home hemo patients, which are mostly short daily, I'm usually using very little heparin boluses. And now that you say that, I'm reluctant to give you a number because I probably need to go back and look and actually see what we're doing. But because
Understood.
yeah, on the top of my
Yeah.
head, I can't. I will tell you that I'm using less than I remember using 10 years ago. You know,
Okay.
a, a few thousand unit bolus, and generally that's all my patients need. And I have a few patients for various reasons that are using no heparin. Most of them are on some form of anticoagulation that they haven't needed that, and we've backed off on their heparin because they've had bleeding from their fistula that lasted long. So I'm gonna have to go back. I'm gonna have to go back and pull my data and see what actually I am doing now, because I just haven't thought about that systematically recently.
Yeah, I was just curious more than anything. No need to look it up, but yeah, interesting.
Thank you. So any more questions from the audience? Okay, so far we don't have any questions. So Well, that will conclude this presentation today. We really thank Dr. Miller for spending your time to teach us about give us a great talk. And well, this will conclude the training and presentation. And have a great day, everybody. Thank you.
Thank you,
Thank you
Joanna.
for
Thank you,
Dr.
everyone.
Miller.
joining.
It's been a pleasure.
Mm.
Thank you,
Bye
Joanne.
bye. Thank you.
Thank you.